So Philip is asking, what's your query, Hillary?
What is he asking?
What is, your question to him? He heard you saying something about him. He wants to know, what do you want?
Yeah. I said we need to contact Dan Cotton.
Yeah. I'll wait 1 more minute and then we start. Just the last one anyway.
He's looking.
Okay. Should we start? Okay. Okay. Hello, everyone, and thank you all for joining us today. On behalf of the Radiology Society of Rio de Janeiro and OCAD, I want to welcome and thank you all. My name is Aline Serfari, and I'm here with Dr. Hillary Humans, who coordinates and moderates this series with me since 2021. Our guest speakers today are Dr. Anne Cotten, Dr. Karina Todeschini, and Dr. Chiara Giraldo. This session will focus on rheumatology. The speakers will present their cases, and at the end, we'll have a Q&A session. If you have questions at any time during the presentations, please put them in the chat box, and at the end, the speakers will respond to them. The presentations today will be recorded and available on demand on the OCAD website, which is ocadmsk.com, and on the YouTube channel of the Radiology Society of Rio de Janeiro. If you want to join the OCAD community and see challenging cases, consider registering on the OCAD website. A quick reminder, attendees have not been given the permission to screen record any of these presentations, as they may contain material under copyright. Unauthorized recording, use, distribution, and sale of this material without permission from the speaker is illegal. We thank you all for your understanding, and without further ado, I will kick off the session. So our first speaker today is Dr. Karina Todeschini. She's a practicing MSK radiologist and medical director at Santa Monica Imaging. She graduated with a degree in medicine from the University of Caxias do Sul with a fellowship in MSK diagnostic and interventional radiology at Hospital das Clínicas de São Paulo. She did a mini fellowship at CRU, Lille, France. She actively participates in educational meetings, showing didactic and challenging cases from her daily routine. Please, Karina, take it away.
Thank you, Aline. Thank you for the kind introduction. And thanks again for giving me the opportunities. Thanks also to Laura Kunzler, kind and brilliant rheumatologist, and Cecile Bara Kurimori for all the discussions. Can you see my screen?
No, I can't.
I'm sharing.
I can.
You can? So it's
Yes.
something on my computer.
So my goal is to show a case that I made the wrong diagnosis and its related cognitive mistakes, to show a companion case, and the discussion will be done as the cases are shown. The patient is a 61-year-old female who came the first time in 2019, referred by the orthopedist, feeling 4th and 5th metatarsal pain. The radiographs were normal except for the previous bunionectomy. The MRI, T1 and T2 weighted images show a neuroma in the 3rd intermetatarsal space and associated bursitis. Also, we could see subcapital metatarsal bursitis, but at the time it was interpreted as overloading changes. There were no synovitis or bone marrow edema. The diagnosis was mortal neuroma and intermetatarsal bursitis. So now it's 2023. The same patient comes with persistent metatarsal pain. She refuses to receive the contrast media. X-rays show, in addition to the bunionectomy, a big erosion at 3rd metatarsal head and focal soft tissue swelling next to the bunionectomy and adjacent to 5th metatarsal head. Joint spaces are preserved. Here is the 4-year evolution. T1 and T2 weighted images show an intra-articular tissue or effusion that causes the erosion. The lack of contrast media is limiting the analysis. Morton's neuromas is still there. Long axis T1 and T2 show the joint distension at 3rd MTP. There is a preserved cortical line of subchondral bone at the base of the 3rd phalanx. Sagittal T2 image show bone marrow edema and joint distension. Contralateral foot radiograph shows an erosion at lateral 4th metatarsal head and subchondral cyst. At this point, as I personally know the patient, I pick up the phone and call her. She was returning from the beach and she told me she exaggerated in drinks and barbecuing. Do you have gout? I asked. She said, no, I don't, but my mother and sister have rheumatoid arthritis, which is probably what I also have. So here are the key alignment. There were no subluxations here. Second is bone mineralization. I personally find it difficult to access just articular osteopenia. These areas that resembles osteopenia, like in here, are in fact normal, related to soft tissue overlap. It's always better to appreciate osteopenia when non-affected joints are available for comparison. Third is bone production, which is characteristically absent in array. In gout, this low erosive process of atophus elevates the cortex, forming the overhanging edge, which we don't see here. But I was not sure at contralateral foot. I will discuss this later. Next is cartilage, or joint space narrowing. It's preserved here. Calcifications are associated to tophus and not seen in our case. Distribution is random here. Metatarsal tarsal joint is spared. Both rheumatoid arthritis and gout can affect the midfoot. The erosion here is the big deal. It's a big and subarticular erosion with thin sclerotic borders. So I put both here and I will discuss also later. And last, here the erosion in detail. And last but not least, soft tissue swelling. There are a lump here and a bump, which is very gouty. So does the case deserve a low energy CT? We thought so, but there were no deposits. Low energy CT is highly accurate in the diagnosis of gout. After the exam, the patient went to a rheumatologist. She had normal serum uric acid levels, positive rheumatoid factor and positive CCP antibodies. CCP and rheumatoid factor have sensitivity around 80%, and CCP are almost 95% specific for rheumatoid arthritis. So the diagnosis is consistent with rheumatoid arthritis. In 2019, I was probably looking at a case of early RA. The disease is considered very early until 12 weeks of evolution and early till 6 months. My first mistake, the fact that the patient was referred by the orthopedist confused me. I thought that the finding was related to overloading changes. This is called framing bias. So the subcapital metatarsal bursitis. What else did I get wrong? We are all prone to cognitive mistakes. It's interesting how we translate image to words in our heads. Bunionectomy is the first MTP change, which unconsciously prevented me to rule out first MTP erosion. There is a 4-year evolution of disease without just articular osteopenia nor joint space narrowing. Subcapital soft tissue swelling at X-rays, and the overhanging edge of at contralateral foot and corticated borders of the erosion are both questionable findings, right? I was not sure, but they are in fact confirmation bias because I secretly wanted to be a gout case. And what did I miss? Even without contrast media, we can see the synovial thickening here. It is possible to see synovitis in acute gouty arthritis, but it wouldn't cause such a big erosion. Also, there is a small aggressive erosion at plantar aspect of the base of the phalanx. The erosions in gout are typically associated with tophi and are seen on dorsal surface of joints. I found this risk from the same patient from 2020. We always perform the Norgard view or ball catcher view when arthritis are suspected. So in a well-performed Norgard view, we should be able to see the radial aspect of the base of proximal phalanges and the triquetrum and pisiform. This radiograph is not perfect, but we can see the beautiful small erosion here in bare area at pisiform. So gout and RA rarely coexist. There are explanations for a negative feedback between these two conditions. Here, there is a companion case. It's a female, 57 years old, also referred from the orthopedist who wants to access Alex Valdez. The long axis T1 and T2 shows an erosion with sclerotic borders at first metatarsal head and a small erosion at the base of proximal phalanx. Midfoot is widely involved. Short axis T1 and T2 shows extension to medial subcutaneous tissue. We performed a dual energy CT, which shows an overhanging edge of cortex in the erosion, but no crystal deposits. Talking to the patient rheumatologist, we discovered she is a long-time known case of rheumatoid arthritis in use of Enbrel and TNF inhibitor. So treated RA is a well-known differential diagnosis of gout. Treatment will allow a reparative response to occur, which gives us erosions with sclerotic borders and overhanging edge of cortex. So take home points. Cognitive mistakes are independent of the observer's experience. Real life is not always by the book. Gout is the great mimicker, but not the only one. Always have in mind the differential diagnosis of early rheumatoid arthritis in cases of intermetatarsal and subcapital metatarsal bursitis. Treated RA resembles gout in image. Background clinical history is essential. Thank you.
Okay, it's my turn to introduce Chiara. She is she took her medical degree and completed her specialty in radiology training at the University of Padua. During her residency, she was a visiting scholar at the University of California, San Diego, under the supervision of Dr. Donald Resnick, and afterwards did an observership at the MSK radiology unit of the Department of Biomedical Imaging and Image-Guided Therapy at the Medical University of Vienna. After the residency, she completed a PhD in medical physics at the Center of Excellence for MR Research at the Medical University of Vienna, and a thesis on the application of diffuser tensor imaging on muscles at 3 and 7 Tesla. During her time in Vienna, she also had a chance to collaborate on several PET-MR projects and is currently working on hybrid imaging, PET-CT and PET-MR. She is assistant professor of radiology at the University of Padua, and since 2021, the chair of the arthritis subcommittee of the ESSR. Her main research focus is musculoskeletal imaging and has authored and co-authored more than 100 articles published on national and international peer-reviewed journals and several book chapters. Okay, Chiara.
Thank you very much. Thank you, Hilary. Thank you, everybody, for the invitation. It's just a real pleasure and honor to be here today with you. Do you see my screen? Is everything fine?
Everything's good.
Okay, perfect. So I will just present a kind of a straightforward case and recall some diagnostic concept that we probably all well know, but sometimes just a short refresher can be useful. So I present a case of a young female runner with hand and foot pain. In particular, she was a 23 years old woman when she came to our rheumatologist. She was a usual runner and also martial arts player. She referred that in the last 5 months, she had an increase in morning pain and stiffness of the right hand and right foot pain, but that especially in the evening. She referred just an allergy to gadolinium, and then we will see how much that will affect our images for later. But she didn't have any comorbidities and no familiar history for any rheumatic disease. When she was assessed by a clinical point of view by a rheumatologist, the rheumatologist didn't identify any specific area of pain in the hands, while on the right foot, the pain was especially the second and fourth metatarsophalangeal joint, especially on the left side. So actually, not where she was referring the pain. So a rheumatologist decided to prescribe X-ray. First of all, she prescribed laboratory examination, and we immediately identified increased levels of ACPA and increased rheumatoid factor. No inflammatory indexes were positive, and the blood count was overall in the ranges, and no other antibodies. After this, of course, as expected, radiographs were prescribed. We can see both ends, the right and the left, and overall they were considered unremarkable, and also considering the positive rheumatoid factor and the ACPA positivity, we could have expected erosions or even indirect signs like soft tissue swelling, which were not seen. I didn't put all the views, but I can guarantee that they were all negative. So also in the head ball views, no particular signs. The patient underwent also X-ray of the feet. You can see also in this case, no particular changes, no particular pathological signs. Our rheumatologist didn't stop here because the clinical symptoms were actually very significant, considering how the patient reported them. And so prescribed an MR. And the patient underwent an MR of one hand and both feet. As you can see, the MR is immediately positive. So we have bone marrow edema of the second and third metacarpal bones and of the proximal phalanx of the second finger. If you look on the axial images, that we can debate also a bit later on, we see what could be defined either a joint effusion or a synovial thickening. If you look carefully on another slides, probably you could even bit distinguish between the two. So we have a bit of joint effusion and also the synovial thickening, which more a front feature. Then the feet were scanned, in this case, both feet, and we can see that there was a bursitis between the third and the fourth metatarsal bones, and nicely seen on the axial view. Again, we have joint effusion, but also probably a bit of synovial thickening, which is even better detected on the left side. So we have symmetric findings in the feet. We have similar findings between the hand and the hands and the feet. So the diagnosis was, as I said at the beginning, it was a kind of a straightforward one. The patient was defined as with early rheumatoid arthritis, immediately started the treatment with methotrexate and folic acid with an increasing dose of methotrexate along the weeks. Then our patient came back to our attention after 6 months of rheumatologist prescribing an MR. And as you can see, again, no contrast medium injection because the patient reported actually a severe allergic reaction to that when she underwent an MR of the brain as she was younger. So no more bone marrow edema in her hand, no more synovial thickening or joint effusion. And if we compare, especially, we can, if you can see the previous images, the change is very significant. If you look at the feet, we had case only the left foot was scanned. If we look carefully, again, we had almost a complete resolution of the signs of the disease, except for still a bit of bursitis between the third and the fourth metatarsal head, but certainly without very positive response compared to the previous imaging. So in this case, as I said, it's a direct diagnosis. It was pretty easy to be seen, but I think that the type of message I would like to deliver today is the fact that we are dealing more and more with cases of early rheumatoid arthritis. We know that rheumatoid arthritis is a chronic autoimmune disease with inflammatory arthritis, with a female predilection. We know that we have various factors which can predispose to the onset of this type of disease, starting from genetic factors to environmental ones. And we have then singular triggers which can onset the disease. I don't want to get into details of all the pathological mechanisms that are behind the rheumatoid arthritis, because we are all, I think, radiologists. So let's focus on what then we can see as a result. But as I always say to my residents, we have to understand what happens before to then interpret correctly what occurs in our images. So we have, as I said, different triggers, genetic predisposition, and then also environmental triggers like the smoke of tobacco or the exposure to dust. And then we have the activation of the macrophage and then T and B cells. And in this case, the main target, and that is what we have to remember, is the synovium. We have then synovial thickening, and what happens on the areas of the bone, the bare areas not covered by the cartilage, we can then have erosions and infiltration as time passes by and disease progresses with the infiltration of the synovium inside. So that is what we can see when we have advanced cases. We know that there are classification criteria we have to rely on, which when we have a score that is above 6, then we can define rheumatoid arthritis. We also know that in the classification criteria, we cannot really rely on images, but the EULAR and the American College of Rheumatology highlighted, especially in the last 5-6 years, that imaging, and not only radiography, but especially ultrasound and MR, are essential to perform an early diagnosis and to support the clinical suspect of rheumatoid arthritis. So what is early rheumatoid arthritis? It was already said before by our colleagues that we define right now what is an early rheumatoid arthritis, what is a disease with an onset with clinical symptoms which started 6 months before the patient came to our attention. The problems that in the past we defined what was early, when the disease was less than 5 years lasting. Then we understood that we had to shorten our times, and then we had the phase of the 24 months. And as I said, right now, our interval is just 6 months. And that shows how much how much is important that we come in a very early phase of the development of the disease. Actually, recently it was proposed a definition of the VERA, so very early rheumatoid arthritis, which should be defined when we have symptoms since less than 12 weeks, which means 3 months. And that is because it has been demonstrated that as early as we act against against the disease, better is the prognosis of our patient in terms of remission. And indeed, we know that if we can come in the early phase, which is mainly characterized usually by synovitis and joint effusion or mild erosions, then we can really prevent all the deformities that we've seen for many years. What is the role of imaging in the early phase of rheumatoid arthritis? Well, X-ray plays a marginal role. We can detect indirect signs if we are lucky, so some soft tissue swelling. Usually we don't see erosions unless the patient have a very severe and active disease, and we don't see the typical symmetric and concentric narrow joint space. What is very useful can be ultrasound, so we can detect synovitis, tenosynovitis, which can be the early signs, bursitis, and we can take advantage of the Doppler to assess the increased vascularity. Again, if there are radial erosions, so of course they can also be nicely seen with ultrasound. MR is essential to see the bone marrow edema. It has been demonstrated that bone marrow edema can be a precursor of erosion, so we have to really pay attention to this finding and do not underestimate it. All the other signs that can be detected in MR can be also easily seen with the ultrasound, as I said before. So MR imaging. We know that rheumatoid arthritis has usually bilateral involvement, and hands are commonly involved in the early stages. If you can perform a bilateral imaging, of course, if there is a time constraint or a collaboration of our patient, a compliance, then choose one hand, choose the one that is more painful or is the dominant. As I said before, synovitis can be one of the earliest signs that we can detect, so we can see the involvement of the tendon sheets or of the bursa. Subchondral edema can be a precursor of erosions. Your protocol can be very easy. So steer into one sequences as recommended in the paper that was published by some years ago by our subcommittee, and post-contrast imaging. That is what we've missed in our patient. And sometimes our rheumatologists say, okay, if we don't have contrast, we cannot really reach a diagnosis. Contrast helps. We can see even the smallest synovial thickening taking contrast enhancement. But as some author recently suggested, we should probably wonder if we really need that to distinguish between the fusion or the synovial involvement. Also because we all know that the deposit of gadolinium could represent a major problems as time passes by, especially for patients who have to undergo several MR examinations. Just a short recall to the treatment. Our patient was lucky, so she could stop immediately, stop not the treatment, but stop at the first step at the first phase of what is the recommendation. So methotrexate had a very good effect. So now our rheumatologist is thinking about a dose reduction to see if the remission is standing on. So if there is no need there was no need to move to any other type of biological drugs or JAK inhibitor that we know are very effective, but have also several side effects. The response to treatment in patients with early rheumatoid arthritis has been demonstrated to represent a very good prognostic factor, prognostic element. Actually, this author recently suggested to reduce the time of the scan, so shorten your interval before after a treatment, and because examining your patient after 1 or 3 months, you can really predict what will be the course of your patient. Just recalling briefly, not for diagnostic use, but if you perform clinical trials. And as I said last week at the ESSR, this is what we have to know and to keep in our mind for our clinical practice, not because we have to apply all these exhausting scores, but just because if we know where we have to look at for a score, that is what we have to put our eyes when we report our in our daily practice. So this is the very complicated primary scores. Thanks God, a much easier score has been proposed. So the simplified versions has been performed later on, and it's quite easy and much better in terms of timing. Last but not least, remember that rheumatoid arthritis is a systemic disease. So this is one of our patients with pulmonary involvement. You can have cardiac involvement. They can be predisposed to malignancies. So do not forget all these aspects. To conclude, so remember that the early or very early diagnosis of rheumatoid arthritis is essential to start an early treatment and reduce the disease progression. You can perform radiographs. I love radiographs, and they can provide you a lot of information, but do not stop there if you believe that your patient could benefit of ultrasound and MRI, and if you really believe that the clinical symptoms and the clinical pattern can correspond to the one of an early disease. Remember that bone marrow edema, even if a specific, could be very important sign because it could predict the onset of erosions, and synovitis is the earliest finding. So get used to look for that, even if you don't have contrast enhanced images. Remember that there are the diagnostic criteria. Remember all therapeutic indications because they can have an effect. You can also, in your report, suggest when this patient could be examined to provide the best therapeutic option. And also remember the radiological scores, although they are quite challenging in terms of time consuming. So with this, I would like to thank you, and I would be very happy to answer to all your questions.
Thank you very much, Chiara. Now it's my pleasure to introduce Dr. Anne Cottin. She's a professor of radiology and head of the MSK Radiology Department at Lille University Hospital, France. She was president of the French-speaking Society of MSK Radiology, as well as of the European Society of Radiology, ESSR. And she's the current treasurer of the International Skeletal Society. She has authored and co-authored more than 250 articles, written 6 books, and given more than 300 lectures. Please, and take it away. I can't hear you. Can you hear her? And you're muted. And you're muted. I can't hear you.
Can you hear me now?
Yes.
I can hear you, yes.
Okay, perfect. Thank you very much for the very kind invitation. So let's start with the first case. You can see this 24-year-old man. He had a history of pain 2 months before with a painful wrist, and he had a history of trauma several years before. So he had radiographs and CT performed elsewhere, which were read as normal, no fracture. So he was referred to our department with a clinical suspicion of occult fracture. And on these coronal T1 and T2 weighted images, you can see a bone marrow edema involving the hamate. And this is confirmed on these axial images. You can see the bone marrow edema of the hamate and of the hamulus. And you can see the enhancement after gadolinium administration. So this may represent a fracture, but in fact, you know that it's quite unusual to have a fracture of the hamulus, particularly near the base of this bone. And in fact, on the adjacent sections, you can see a more rounded appearance of this lesion, which is surrounded by a hypointense sclerotic rim. And in fact, on the initial CT scan, a small osteoid osteoma could be depicted, and this osteoid osteoma was indeed responsible for the pain of the patient. So as you know, in young people, the main etiologies of bone marrow edema of the carpal bone include fractures, and you have an example of a fracture of the trichotrom, and of course, osteoid osteoma. Several weeks later, this patient was referred to our department because he had the vague pain for 1 year with a recent increase, no history of trauma. And on these images, you can see bone marrow edema of the hamate. This is again confirmed on the axial section. You can see the high signal intensity of the hamate and of the hamulus, enhancement after gadolinium administration, and a predominance of the low signal intensity at the hamulus on the T1 weighted images. So, of course, we looked for an osteoid osteoma that we couldn't find, but in fact, three features drawn our attention. First, the presence of extensive inflammatory changes of the adjacent soft tissues. Second, the involvement of the transverse carpal ligament at its attachment site, as you can see here. And third, the presence of irregularities of the outlines of the hamulus. So we decided to perform a CT scan, which confirmed the presence of hyperostosis of this hamulus. And in fact, this association, osteitis, enthesitis, and hyperostosis is highly suggestive of psoriatic arthritis, which is, again, one of the main etiologies of bone marrow edema involving a carpal bone, and particularly in young patients. Retrospectively, the radiographs were not all that normal, and if you look at the hamulus, you can see that on the right side, this hamulus has irregular outlines in comparison with the left side, but of course, it's always easy to say afterwards. So during the rest of my lecture, I will focus on several MR features which may be useful for the depiction of psoriatic arthritis at the wrist and at the hand. So at the wrist, of course, the distribution, and you know that a unilateral or an asymmetrical involvement of the wrist is more frequently seen in psoriasis than in rheumatoid arthritis. As synovitis and tenosynovitis are not specific MR features, so the distribution is interesting, but much more interesting is the presence of osteitis and enthesitis, such as in our case. But this is another case, another patient, and you can see inflammatory changes involving the attachment site of the transverse carpal ligament. And this is another example. You can see inflammatory changes at the attachment site of the flexor carpi ulnaris tendon. Two particular features associated with osteitis and enthesitis are also interesting to depict when present. First, hyperostosis, such as in our previous case. This is really very suggestive of psoriatic arthritis. This is another example. You can see osteitis, you can see erosive changes, but you can see also hyperostosis at the anthesal attachments. And you know that this area is an area where the extensor carpi ulnaris tendon and the capsuloligamentous structures attach onto the bone. So this is highly suggestive of the psoriatic arthritis. And in fact, if we look back at our case, you can see the edematous changes of the image, but there was also an involvement of the capsuloligamentous structures, which means that an enthesitis was also present. And if we look at the radiographs, you can see the irregular outlines of the bones, but once again, it's always easier to say afterwards. Look at this other case. You can see edematous changes of the lunatum and of the trigetrum, but you can see that the bone marrow edema predominates at the attachment site of the lunotrigetal ligament, as well as at the capsuloligamentous attachment onto the trigetrum. But if you look at the axial images on this T1 weighted image, you can see the irregular outlines of this bone related to hyperostosis. Look at this case I showed you before with the enthesitis of the flexor carpi ulnaris tendon. If you look at the coronal T1 weighted image, you may see the undulated appearance of the pisiform. And on this sagittal T1 weighted image, you may see a hyperostosis involving the distal radius and the lunatum. But of course, radiographs may also be helpful, but frequently we do not have the radiographs when we have to report the MR imaging. As another striking feature of psoriatic arthritis when present is the presence of extensive osteitis. So you can recognize this case I showed you before, but you may see in the same patient this extensive osteitis of the first metacarpal bone. Such inflammatory changes cannot be explained by this adjacent synovitis and maybe a joint space narrowing. It is too extensive. This is highly suggestive of psoriatic arthritis. Look at this other case. There is a joint space narrowing, but this cannot explain such extensive inflammatory changes of the distal radius and of the carpal bones, including the trigetrum, which is not involved in this joint space narrowing. This is also highly suggestive of psoriatic arthritis. If we look at the digits, once again, the distribution is important. You have more frequently a unilateral or asymmetrical involvement of the digits in psoriatic arthritis. But as you know, involvement of an entire digit, that is MCP, PIP, and DIP joints, or of the MCP and DIP joints, such an involvement is highly suggestive of psoriatic arthritis, as rheumatoid arthritis involves the MCP and PIP joints, osteoarthritis, the PIP and DIP joints, and CPPD, the MCP joints. But of course, it's very interesting to depict enthesitis, such as the capsuloligamentous thickening in this patient and with an increased signal intensity. Or you can see also this enthesitis on this sagittal section. And do not forget to look at the pulleys, which are also entheses and which may be involved in psoriatic arthritis. Osteitis, of course, if you depict these inflammatory phalanges, intermediate and distal phalanges shows a high signal intensity on these T2 weighted images. Look at this inflammatory phalanx highly suggestive of psoriatic arthritis. Look at these extensive changes, highly suggestive. And you can see this osteitis involving these two phalanges, highly suggestive of psoriatic arthritis. Sometimes periosteitis may also be depicted on MR imaging in association or not with adjacent inflammatory changes of the bone. This is much more frequently depicted in psoriatic arthritis than in rheumatoid arthritis, for example. Dactylitis, of course, which is this circumferential thickening of the soft tissue surrounding the bones, as you can see here, but it's usually easy to depict on the clinical examination. This may be seen in isolation or in association with other features such as synovitis, enthesitis, or osteitis. And finally, do not forget to look at the nails. For example, in this patient, you can see obvious inflammatory changes of the distal and intermediate phalanges with involvement of the adjacent soft tissues and probably involvement of the capsuloligamentous structures. So the diagnosis is already obvious for psoriatic arthritis. But if you look at the nails, you can see the increased signal intensity of the nails of the same digit in comparison, for example, with this adjacent nail. So this is not helpful in this case, but look at this other case, a 36-year-old woman with no known skin psoriasis. You can see a mild bone marrow edema of this distal phalanx, with some involvement of the adjacent soft tissues. You may also see probably an involvement of this capsuloligamentous structure. But if you look, if you go on the axial sections, you can see the increased signal intensity of the same digit, of the nail of the same digit in comparison with the signal intensity of the adjacent digit. But interestingly, if you look at the fourth and fifth digit, you can see an increased signal intensity of the nail. And interestingly, this woman consulted a dermatologist who confirmed the presence of psoriatic onychopathy of the second, fourth, and fifth digits. So I'm not saying that it's interesting to perform MRI of the nails, but it's interesting to look at the nails when you perform MR imaging of the digit, because sometimes, particularly when you have a distal involvement with no obvious features, sometimes you may see some differences. So in conclusion, we have seen several MR features at the hand and at the wrist that may be useful for the depiction of psoriatic arthritis. Thank you for your attention.
Thank you all for the amazing cases presented today. There is one question from the audience. Edward Brown is asking if is anyone doing dual energy CT for CPPD? He wants to know.
Not me.
Oh, anyone? Okay. Next question from Edward Brown to Anne Cotten. Is ultrasound more sensitive than CT for CPPD?
For CPPD, well, I think that we should perform ultrasound first because it's easy to perform. It's interesting to, in fact, you know where the people have pain, so you can assess the joint where painful. And you may see, of course, chondrocalcinosis quite easily because it's superficial. So I would say that I would prefer ultrasound compared to a CT.
Okay. someone is saying, I just want to precise that in psoriasis, arthritis, the poly A3 is most commonly affected than A1, but it's not a question. And I think that's all from the audience.
I had
Hillary.
some questions. I had some questions that I was chatting with Chiara and Karina about. I was curious about the reference that Chiara was talking about, not using intravenous contrast to differentiate synovitis from, I guess, effusion. And I was wondering what pulse sequences were most helpful for that.
I think, thank you for addressing that. I mean, putting that paper was kind of provocative on my side, because and actually was related to the fact that I didn't have the chance with this case to inject contrast medium. So I just and I thought, okay, well, let's see what the literature also says, if they are unlucky as I was in this case. But the authors of that paper kind of try to avoid the difference between joint effusion and synovitis. I mean, how we are good in differentiating between that. So I mean, I don't know them personally, so it's nothing bad against them. But,
I mean, I wonder what Karina and Anne think. Obviously, STIR or fat suppressed fluid sensitive sequences will show us fluid, but I feel that can blur the distinction between edematous thickened synovium and just bland effusion. And I've noticed, incidentally, that in some cases I see the thickened synovium better on T1, but everyone doesn't, routinely do T1, or if non-fat set proton density would be helpful. I mean, I'd open it up to anybody.
Yeah, I completely agree with you, Hilary.
I agree also. I think hypersignal in T1 helps me a lot to differentiate.
Yeah. Yep. I think that then you have very extensive, severe cases, then you have also the shape, the front shape that can help you. But in early cases, I mean, if you have the T1 can help, but at the end of the day, it's fluid or synovium without a contrast. It's really hard.
Okay, and then I had another question for Karina that I was chatting about. Recently, I had a strange case that I shared on the OCAD online forum, and I was wondering, it looked to me like it might be gout, but it seemed to be infiltrating the meniscus, and I had never seen that. And I don't have access to DECT where I work. And Bruno Vandenberg actually suggested that conventional CT can be helpful. And he said that using the soft tissue kernel, tophi can have an attenuation of 150 to 250 Hounsfield units. And I was wondering if it would be helpful if you didn't have, like obvious tophaceous gout. I didn't know if it's helpful at all, if anyone has experience with that.
Well, for the gout, CT may be particularly useful because it can show you increased density with blurred limit. So I think that if you cannot do dual energy, that might be helpful.
Okay, good. That's exactly what he suggested to me. So I remember back in the old days when I was training, and I was taught that there were, so many different types of presentation of psoriatic arthritis, and that one form mimicked rheumatoid arthritis, and I mean that's really what you were showing us at first. Do you have any sense why this might be? I mean, it's curious to me that all these conditions are treated with the same DMARDs.
So your question is why two different diseases can be...
I mean, do you think they're really different diseases? I guess that's what I'm asking.
Well, everything is related to immunity and biochemic changes. So, but it's strange that the distribution of arthritis and of the lesions it's completely different in these two disorders. But you're right, it's the same treatment with mild changes, but it's mainly the main treatment, yes. I don't know if Chiara has for you, because it's a difficult question, but
it's very hard. I mean, I think that we are maybe we would be better with our rheumatologists would be better in the treatment in the future. In terms, I think that so far we are just trying to suppress the type of inflammation that is occurring and not yet targeting what is really happening. So maybe we will, but will be better in the future. I don't know, but I agree with Anna. In terms of imaging and what happens, they act differently. But yes, the treatment is so far is the same.
Okay, any more questions? So thank you all for tuning in today. We'll take a short break in July, and we'll resume our activities on August 24 for a session with focus on sports imaging. See you there. Bye-bye.